Hello, I'm Dr. Sean London, a diagnostic radiologist with Prenuvo in California. Prenuvo provides radiologists like me with a rare opportunity to diagnose cancer and disease early so that we can have the positive impact we had hoped for when we joined medical school. At Prenuvo, we use a machine called an MRI to get high-quality images with zero radiation. An MRI uses a superconducting magnet to generate images from your body's natural composition. MRI generates images in three distinct planes: axial, sagittal, and coronal. Instead of using contrast or dye, our machine instead uses diffusion-weighted imaging, a special functional sequence that detects abnormal tissue hardness. Unlike imaging centers that are trying to do many things, at Prenuvo, we work to perfect whole body screening. I am excited to take you through the images we acquire and how we use them to put together a comprehensive picture of your health. So we're going to begin with the head, and then we'll make our way down through the body. But we'll start at the skull base, and to give you orientation, you're laying on the exam table, and I'm looking up from your feet. So this is your right ear, and this is your left ear. So the first brain tissue that we see is called cerebellum, which is right here. And this looks completely normal. It's normal volume, normal signal, and no mass is seen in here. Then I continue to go up and I see brainstem, also looks normal, normal signal, no mass, no suspicious findings. And then as I continue to go up, we see more brain tissue. Here's the right cerebral hemisphere, and here's the left cerebral hemisphere. And again, all this brain tissue looks very normal. The first thing that I look for is the brain volume normal? And in this case, it is. The way that I can assess for that is, one, by looking at the central structure called the ventricles, where the CSF is made. This is the fluid that bathes your brain and spinal cord. Now, if this got larger, then that would be an indication that the brain tissue centrally is decreasing, or we're losing volume there. The other way that I can look is in the periphery and between the grooves of the brain. And if that space enlarges, that's an indication that we're losing volume peripherally. In this case, all this looks very normal, no signs of volume loss. The next thing that I look for is a brain mass. We see no brain mass in here. And then I also look for something called white matter disease. And what I mean by that is we're looking for white spots in the tissue around this region. Now, these are very non-specific and can be from numerous etiologies. They can include things like old trauma, if you've ever had head trauma. Could be from high blood pressure that's uncontrolled, diabetes, chronic migraines, and then the autoimmune diseases such as multiple sclerosis. Here we do not see any white spots, so there's no concern for any kind of white matter disease going on here. The next thing we do is we go and look at the brain from the side. So here's the profile, here's the nose, and here's the back of the head. Now, the nice thing about this sequence is that I can look at all the midline structures. So right here, this is called corpus callosum, and this connects the two hemispheres together and also looks normal. And then I get another look at the brainstem connecting down to the cervical spinal cord. This also looks normal. And then I can also see the pituitary gland, which is like the hormone control center. So in this case, we can see pituitary tissue right here, and it has a U shape in this case because some of the fluid that bathes the brain has actually herniated down into this space and pushing on it. But that's a benign finding and generally of no clinical significance. The other nice thing about this particular view, looking at the brain, is I can see all the dural veins that drain the venous blood from the brain. And what I'm looking for here is any bright signal within those veins, which could indicate some blood clot. So here we see nice homogeneous low signal, so no signs of blood clot. And then we can go over to our diffusion sequence. The nice thing about the diffusion sequence, it acts as a functional sequence for us. So we're looking for firmness or highly cellular things like tumors or acute strokes. And here, what we'd be looking for are any dark spots within the brain tissue here. And we see no dark spots. So no abnormal signal on this sequence. So very much a normal looking brain. So now that we've seen a normal brain, we can look at an abnormal brain with a specific condition, when I was referring to white matter disease. So here, on this axial image right here, we can see that there's white spots around the ventricles. the ventricles, again, are where the CSF, the fluid that bathes the brain and spinal cord, is made. So we can see that they're bordering this posterior part on the left, also the posterior part on the right. And even if I scroll up, we can see some more peripheral still within the white matter. And again, there's kind of a laundry list of reasons why these can actually occur. But I think in this case, with the appearance and distribution, what we're dealing here is with something called chronic small vessel ischemic change, and generally related to either hypertension or diabetes. Now, if I want to find out if these are new or acute, I can go to my diffusion sequence, that functional sequence that tells me if these have just occurred or if they're like months to years old. And that the way I do that is I go and find where those white spots are, and then I look at the diffusion and I see if there's any corresponding black spots on there, and I don't see any. So that tells me that these are old, at least months to years old. The other thing that we notice with this brain compared to the last brain is that the ventricles are larger and that the grooves in the periphery between the brain tissue are also larger. So this is an indication that there's very mild generalized volume loss, likely age-appropriate involutional changes. The next thing we look for are brain aneurysms. These can either be congenital, you're born with them, or they're acquired due to either uncontrolled blood pressure, drinking, smoking, anything that hurts the vessel walls. And what happens is the wall becomes weak. So it tends to happen at where the vessels change direction. So here we can see the right internal carotid artery and the left internal carotid artery coming up from the neck and going into the brain. And then they split off, and this goes and feeds the left side of the brain. Here's the mirror image on the right going and feeding the right side of the brain. These vessels here feed the central portion of the brain. And then this big vessel back here feeds the posterior part of the brain. And now we can see all the vessel walls are very smooth. And so there's no outpouchings, no signs of aneurysm. And all the vessels look widely open. So this is very normal. So now that we've seen what normal cerebral arteries look like, I'm going to show you what an abnormal look like with an aneurysm. So here on the left side, we see the left internal carotid artery coming up toward the brain. And we see an outpouching arising from the left lateral wall of the left internal carotid artery. So this is a great example right here of how the wall has gotten weak and created a outpouching or a balloon sticking out. Now this probably measures around 3 millimeters. So overall, if the patient has low risk factors, the risk of 5-year rupture is relatively low, less than 1%, and can likely be surveilled safely. So the next thing we look at are your sinuses. So the sinuses are air-filled structures in the forehead and the facial bones. So the first thing we see here is the frontal sinus, and we notice that it's all black. And that's how we want it to look, because air on MRI is black, and we want our sinuses to be air-filled. So when we get sinusitis, what happens is the tissue lining the sinus becomes thickened, which is an indication that there's inflammation going on. And that's usually an indication that there's chronic sinusitis. Now, if I saw fluid layering within the sinus, that would be concerning for acute sinusitis. Generally, it's acute on chronic sinusitis is the picture that we see. But then as I scroll down, we have more sinuses between our eyes called the ethmoid sinuses, behind our eyes called the sphenoid sinuses, and then also within our cheek called the maxillary sinuses. And all these sinuses look well aerated, they're black, and there's no signs of acute or chronic sinusitis here. Then I travel behind the nose into the area called the nasopharynx. Now this area communicates with the middle ear, and here's the eustachian tube on the right, and here's the eustachian tube on the left. And what we're looking for here is abnormal tissue growth either on the left or the right. And now what that would indicate is a possible nasopharyngeal cancer. And now this area is really important for us to look at because on clinical exam, nobody can see this unless they take a camera and go through your mouth or nose and directly visualize. So in our case, our exam is a great opportunity to visualize this. And here we can see that there's no asymmetric soft tissue. So there's no concerning findings for any kind of nasopharyngeal cancer here. I also go further back and I look at air-filled structures within our temporal bones called mastoid sinuses. And sometimes when we have obstructing tissue in the nasopharynx, we can also get fluid buildup in our middle ear and fluid buildup in these sinuses here. But yet, just like the other sinuses we looked at, they're black and filled with air, so these are normal. No concerning findings, no inflammation. Then we travel over to this right image here, and now we're going to look at our salivary glands. They're paired structures on the sides of our face. So the first ones we see are the biggest ones by our ears, called the parotid glands. Here's the right parotid gland and here's the left one, and both look symmetric and normal. There's no mass in there and no fatty atrophy. And then I keep going down further, and here's the tongue, and I look under the tongue, and we have more glands called the sublingual glands, and these also look symmetric and normal, no concerning findings. And then I go right under your jaw, and these are called the submandibular glands, and these also look symmetric and normal. There's no concerning findings, no duct obstruction. Sometimes people get stones in these, but I don't see any signs of stone. I would see a dilated duct or inflammation surrounding the gland. So this all looks very normal. Then I travel through the soft tissues of the neck as I head further down, and I'm looking for lymph nodes. Now, this patient here has very normal looking lymph nodes, and we can see one right here. It's normal size and shape. The reason I look for these is if I see an abnormal lymph node, it can be a sign that there's an infection going on or possible cancer, but these all look very normal. And then I go to the base of the neck, and here we are. Here is a black circle. This is the trachea. Again, it's filled with air, so that's normal. And overlying the trachea is our thyroid gland. So in this particular case, this thyroid is actually quite small. So here's the right thyroid lobe, and here's the left thyroid lobe. Now, I don't see any suspicious findings in the thyroid here. There's no nodules or masses, but the fact that the gland is so small indicates to me that there's likely a diffuse thyroid disease going on, such as hypothyroidism. And we tend to see this as the thyroid gland burns out and stops producing thyroid hormone. So now that we finish the neck, we travel into the chest. The first thing that we look at are the lungs. So here, this is axial orientation again. So this is the right side, and here's the left side. So here's the right lung, and here's the left lung. Again, they're black, so they're filled with air. And then the white streaks that we see here are the vessels. Now, what I'm looking for here are any kind of pulmonary nodules or masses. And in this case, I don't see anything worrisome, no nodules or masses, no signs of infection. So these look normal by MRI. Now, there are some limitations with MRI when we're looking at the lungs relative to CT, for example. With CT, we can get a bit more detail with the microarchitecture of the lung, like the interstitium. So people with like chronic interstitial lung disease would benefit from a CT as opposed to an MRI in this case. But for screening exams, this serves its purpose really well. So we can say there's no suspicious findings in the lung, and I can also support that by looking at my diffusion imaging, looking for that firmness, those highly cellular masses, and I would see any kind of black nodules or masses on this sequence, and I don't see anything there. So I feel confident that we don't see anything concerning here. The other thing that we look for is any kind of abnormal fluid accumulation around the lung. The best way to do that is to look at this specific sequence. It looks kind of black and white, and what that means is anything really bright or white is going to be fluid. So if we saw abnormal fluid around the lung, we would see that white signal surrounding the lung tissue here or here, and we don't see any of that. We also look for abnormal fluid accumulation around the heart, which is over here in the central portion of the chest. So here's the heart right here, and this is a normal size heart. But if I saw abnormal fluid, we would see kind of a thickened white rim around the heart, but we don't see that in this case. Now that we're talking about the heart, there are other limitations that we do have with our exam, specifically looking for coronary artery calcification. We can't see calcification very well on MRI. So there are better tests to look for that kind of process, but overall, this heart looks very normal. Then I look at the aorta coming out of the heart. So here's the ascending part, and it goes up like a candy cane, makes an arch, and then comes all the way down and goes into the abdomen. What I'm looking for here is any abnormal dilatation, like an aortic aneurysm. I don't see any aneurysm here. This is a very normal sized aorta, so nothing concerning here. We also look for lymph nodes in the central portion of the chest and in the armpit regions, the axillary regions, just like we did in the neck. I don't see any abnormal lymph nodes centrally, nor do I see them in the axillary regions on both sides. So now that we've seen what normal lung looks like, let's see what abnormal lung looks like. So here in the right lung, we see a round mass in the mid to upper portion of the right lung. And when I look here on the coronal image, I see a corresponding mass right there. And then if I go over to my diffusion image, my functional sequence that looks for firmness or cellularity, we see a dark spot. So the combination of the appearance of this with the diffusion tells me that this is a concerning lesion and suspicious for a lung cancer. After looking at the chest, we do look at the breast tissue as it is included in the field of view. And we can see here's the right breast and here's the left breast. In this particular case, these are considered fatty breasts. Now there's different density of breast tissue that women can have. It can be anywhere from fatty to scattered glandular tissue to heterogeneous or really dense glandular tissue. Now, in general, really dense glandular tissue can be somewhat problematic when we're using screening mammography because the x-rays can have trouble penetrating the dense tissue. Whereas on MRI, particularly using the diffusion-weighted imaging, can help us sort through that dense tissue and find small masses that may be missed on mammography. However, this is not really a replacement for mammography and more of a supplement, as we cannot see calcification, and we really want to pick up those microcalcifications, that really early stage breast cancer or pre-breast cancer that we cannot detect here. So while this isn't a replacement for mammography, it is a supplement. Both exams complement each other. So we've now finished looking at the chest and we go down into the abdomen. The first thing that we see in the abdomen is our liver. So that's the big organ in the right upper quadrant, and it looks like this here. First thing I look for is contour. Is it smooth? The liver contour here is very smooth. I don't see any suspicious masses in here, and it all looks a normal signal. When I go down to these two bottom sequences, I can look for either fatty liver disease or iron overload. Now, the reason I care about both of those things is if they're long-standing, it can cause liver damage and predispose to possible liver cancers. The way I look for those is, first I go over to this right image here, and I look at the signal of the liver, and I see if there's any kind of decreased signal relative to the spleen. And here we don't see that. We see the liver maintains its signal and it's brighter than the spleen. So there's no signs of fatty liver disease. Then I go over to this sequence here, and again, I look at the signal of the liver, and what I'm looking for is the signal to get really dark, almost black. And if it does, that's an indication that there's too much iron in the liver, but we don't see that here. So no signs of fatty liver disease, no iron overload, no suspicious masses, and no chronic liver disease. Then we travel further down underneath the liver and we see our gallbladder. It's this bright structure filled with fluid. Now, the most common thing that I'm going to see in there are gallstones. They look like black rocks. Why do I care about those? Is if they get into the neck or into the bile ducts, they can cause obstruction, backup of bile, then it causes pain, inflammation, and a lot of discomfort. So what we usually end up doing in that case, if there was ever an obstruction, is they take your gallbladder out and then you feel better and you can keep living life happily. The other thing I'm looking for is if there's any abnormal thickening, particularly asymmetric, would be concerning for a gallbladder cancer. We don't see that here. And then I also look for the bile ducts to make sure that they're normal size. Now, if I see an abnormal bile duct that's dilated, I have to make sure that there's no obstructing mass, stone, or stricture. So in this case, we can see here is the common bile duct draining down from the liver and gallbladder, and it comes all the way down through the pancreatic head and goes into the first portion of the small intestine. And here it's normal size, so no signs of obstruction. Then that takes us into the pancreas. The pancreas is a sausage-looking organ in the central abdomen. So here's the pancreatic head, here's the pancreatic neck, body, and tail. So this is a very normal looking pancreas. It's normal signal. There's no signs of any mass, and there's no fatty replacement. Generally, we see fatty replacement with either aging or diabetes. Also, we do look at the pancreatic duct just like we did the bile ducts to make sure it's not dilated. If I see a dilated pancreatic duct, particularly if there's no history of prior pancreatitis with inflammation, then I'd be suspicious that there's a mass in there, so we'd have to do further investigation. But here, this all looks very normal and no signs of any kind of suspicious pancreatic masses or inflammation. Then we move up into the left upper quadrant and we see the spleen. The vast majority of things that I see in the spleen are statistically likely going to be benign. Here we see a normal sized spleen, it's normal signal, nothing concerning. Then we travel down a little further and we see our adrenal glands. They sit above our kidneys. Now here's the left one, looks like a Y, and then we see the right one, also looks like a Y, and these are normal looking. Now, what's unique about MRI is if I see a nodule or mass in the adrenal gland, I can actually characterize it as likely benign versus malignant. And the way I do that is the same way that I did when I looked for fatty liver disease. I would go and look at this sequence right here, and if I saw a decreased signal within that nodule or mass, that would indicate to me it contains fat and it's likely a benign adenoma. Nothing to worry about. The one thing I can't tell is if it's hypersecreting, its functional status. That's where we need blood tests and to correlate with any kind of clinical symptoms. Then I travel further down and look at the kidneys. So kidneys are paired structures on both sides of the spine. Here's the right kidney. Here's the left kidney. And both of these kidneys look normal in size, shape, and position. I see no signs of obstruction. Just like when we looked at the heart, I couldn't see calcification very well. Same thing here. I won't be able to see calcification within the kidneys, meaning I can't see renal stones very well, kidney stones. But if there was a kidney stone here that was obstructing, I would see the obstruction. The other thing I look for is, do I see any concerning masses in the kidneys? Here, I don't see anything suspicious, but I do see benign lesions, meaning I see simple cysts. For example, right here, this bright one. And then I also see something that looks like a hemorrhagic cyst. And this is what's unique about MRI, is that I can characterize this as a hemorrhagic cyst because I have the different sequences to show me the different signal intensities of the content within the lesion. So this is confirmed to be a hemorrhagic cyst, nothing suspicious, nothing to worry about. Then we go and look at the intestine, specifically the large intestine, the colon. So we can see here, here's the right side, right here, and then it travels all the way across the abdomen to the left side, and then comes all the way down toward the pelvis and out. Now what I'm looking for here is abnormal wall thickening. So you can see here, here's the wall, and it's nice and thin. I don't see any constricting mass or abnormal wall thickening. If I did see any abnormal wall thickening, I would go over to my fluid sensitive sequence and see if there's any bright signal in there. If I saw really bright signal, that would indicate to me that there's an inflammatory process going on. If it looked kind of gray signal on this sequence, then I would be more suspicious for a possible colon cancer. Now, we do, again, have limitations looking at the colon on this particular exam. As you can see here, all this kind of white gray stuff within the lumen, the center portion of the colon, is all stool content. So you can imagine that if there's any polyps in there, I won't be able to see them because the stool masks the polyps. So that's why we still advocate for colonoscopy screening in this setting. Then we go into the pelvis and we look at the pelvic structures. So in particular, in a male, we're going to look at the prostate. Here we're doing dedicated sequences looking for prostate cancer. We're using this sequence right here, the axial T2 sequence, and then we're also using our diffusion sequences, the functional sequence looking for firmness or cellularity. Now, when I look over here, we can look at the prostate gland, which is normal size here, but more centrally, we see some nodularity and then some enlargement here. So this is typical of prostate enlargement. Then I go over to my functional sequence, and again, I'm looking for any kind of abnormal signal. Do I see any dark spots here and dark spots here? I don't. So I see no suspicious findings for prostate cancer. And I don't see any big lymph nodes surrounding the prostate. So benign findings. I also look at the bladder, which is right here, and it's distended with fluid. It looks nice, thin walled, and I see no filling defects. So no suspicious findings for any kind of bladder cancer here. As we did for males, we also look at a dedicated view of the pelvic structures for females. So in this case, we're taking a side-on view of the pelvic structure here. And here's the uterus right here. And we can see the endometrial stripe, this bright white line going all the way down. And now this is a normal looking endometrium. It's normal thickness. I don't see any signs of a mass within there and no abnormal signal. If you come down a little bit further, we see this small outpouching right here at the lower portion of the endometrium. This is very typical of a C-section scar, so nothing of concern. Then I go down further, and this is where the cervix is, and this all looks very smooth and homogeneous. I see no signs of a mass or anything concerning. We do see small cysts in the cervix, which are very common and can be a sign of inflammation or chronic inflammation, but nothing of concern. And then I look at each side of the pelvis, looking for the ovaries. So in this case, here is the right ovary, and we see a bunch of small cysts within the ovary. These are called follicles. These are a normal finding that women have. They're of no concern. And we go to the left side, and we see the same thing in the left ovary, small follicles, which are also normal, so no signs of ovarian masses. Now we're going to look at the spine. Here we have a full field of view of the spine from the side-on sagittal view. And what we can see here is the cervical spine, the thoracic spine, and the lumbar spine. And now what we evaluate is first we look at the curvature, and this is a normal curvature in the cervical spine, a nice curve in the thoracic spine, and a nice curve in the lumbar spine. And then we look at the bones that make up the spine, called the vertebral bodies, which are the blocks right here. And in between each bone is the intervertebral disc, the cushion. And now the cushions should be brighter than the bone, as they are in this case. So far we see normal vertebral bodies and normal intervertebral discs and very normal looking spine. Then we look for any kind of signs of degenerative disc disease. And that's when the discs start to degenerate and bulge backwards. And that's where we can start to get neural impingement, either on the exiting nerves or on the spinal cord itself. Here we don't see any significant disc bulge, and the spinal canal looks adequately patent. Then we also evaluate the spinal cord. And here we see a normal signal spinal cord and normal caliber without any suspicious cord lesions. Now we're going to look at a spine with degenerative change. We all develop degenerative change in our spine at some point in life. It typically depends on what the disc is doing to the spinal cord or nerve if we actually develop symptoms or not. If we look here in the cervical spine, we can see the spinal cord right here and the bright fluid surrounding the spinal cord. And then we can see at the C4-5 level, we have a shallow disc bulge going posteriorly, but the fluid is preserved between the spinal cord and the disc. So we know that there's no cord compression or any kind of neural impingement in this case. Then if we go down further in the lumbar spine, we can see that at the L2-3 level, we have disc height loss because there's a decreased space here. And there's actually slippage of the vertebral body with respect to the more inferior one. So L2 has slipped slightly forward with respect to the more inferior L3 one. And what that results in is narrowing of where the nerves exit the spine. So if I go out more lateral to the left side here, we can see that there is narrowing of the exit for the L2 nerve, but we don't see any compression of the nerve. So this would unlikely be a cause of any kind of neural symptoms or neural pain. Next, we look at the joints. Now, we're doing more of an overview of the joints and giving you an overall status of the degree of arthritis that you may have. So the first thing I do is I look at this sequence right here. So this is the right shoulder, and what I'm looking at are the bones. So this is called the acromioclavicular joint of the right shoulder, and what we can see here is joint space narrowing, bony spurring going up and down, and this is typical signs of arthritis. Now in this particular case, this is a moderate degree of arthritis, so this patient may experience pain. Then I go over here on this sequence, and what I'm looking for is any kind of abnormal bright signal within the bone, which can indicate swelling, edema. And then I'm also looking for abnormal fluid, either within the joint or around the joint. And here we can see a little bit of fluid within the joint, but I don't see any swelling within the soft tissue around the joint and no fluid collections. Then we travel down and we look at every joint the same way. So here I go down further and I'm looking at the sacroiliac joints. So here's the right one and here's the left one. These look nice and smooth, no signs of bony erosions or any kind of swelling or bone marrow edema, and no signs of sacroiliitis. So these are normal looking sacroiliac joints. Then I go to the hips, and here's the right hip, and here's the left hip. Now in this particular case, we don't really see much arthritis, but what we do see is bony prominence at the head-neck junction of the right femur. And what that can do is that can predispose to a specific type of hip impingement, and it can hit the labrum here and cause damage. Now, it doesn't mean it will, but it is a risk factor for developing impingement. Then I go over here, and again, as I did in the shoulders, I'm looking for abnormal fluid either within or around the joint. And here we see some fluid within the left hip joint and a little bit in the right hip joint as well, so small hip joint effusions. And then I travel down even further, and I'm looking at the knees, the same way I did with the other joints. And here I can see the left knee, and here I can see the right knee, and I don't see any signs of bony spurring or joint space narrowing, so no significant arthritis here. And I go over to see if there's any abnormal fluid either within the joint or around the joint, and we see normal fluid in the joint and no abnormal fluid around the joint.